Okay, so I guess we can get started now. Thank you so much for coming. I'm Michelle. Just introduce myself, and Abigail, you want to introduce yourself?
So my name is Abigail. Thank you again for coming. You can just start whenever you're ready.
Oh, awesome. Okay, great. If you guys have questions or anything, or if drop them in the chat and I will try to stop along the way. And Abigail, you as well, if you need to just have me pause, you think it's best to answer some questions there, let me know. Interrupt me at any time. I'm just going to share my screen. And let's get into it. Put this down. So I am Kavita Jackson. This is my email, this is my blog, and this is where you can find me on Instagram. I'm going to talk to you a little bit about emergency medicine today. So the training that it takes, because I think depending on where you're at in your training, this is just starting with undergrad. So it takes 4 years of undergraduate college. You need a 4-year undergrad degree, having taken the pre-med prerequisites. So that's like your chemistry, your biochem, your calculus, physics, things like that. Oh, you just gotta like get through those, and then you can move on and forget them. But get through those, get your MCAT test done, and then you can be ready to apply for medical school. So I did all that. I took my MCAT twice because I really didn't do so great. As you can probably tell, I was not particularly interested in any of those classes. So I did a post-bac that I just kind of honed in on how I could kind of best study through them, even though I didn't think they were as interesting, because I had to do it to get to med school. So I honed down my study habits and figure out how to learn it and perform well in my MCAT, and then I applied to med school. So the post-bac is not something that's required. That's something that you could take for a lot of different reasons. You could do post-bac. So then you go to med school for 4 years. You start taking your step exams, your step 1, your step 2. Then you go. After I graduated, I did a residency in emergency medicine. So that's a 3 to 4 years, and that's a whole conversation in itself. And then when you graduate and you take step 3, you're an attending. So I'm an attending right now. I graduated in 2019. Then you take your written and your oral boards, actually after you're an attending and after you're practicing, to become board certified. And then there are some fellowships and other types of training you can add onto this in emergency medicine. So I say a day, but really also a night in the life of an ER, because we work days, nights, weekends, holidays, you name it, we work it. No 2 shifts are the same. So when I show up on shift, I show up, I sign out, which means transfer care of patients from the people that are already there to myself. And then I start seeing patients. As you can guess, in the ER, we see the sickest people first. So not necessarily who's been waiting the longest. It's not first come, first serve. It is sickest patient first. And that's why we have a triage system in the waiting room. So on any given shift, I'm usually seeing about 10 different patients at a time. And over the whole shift, I see about 25 to 30 patients. So that's people of different ages. I see kids, I see anything from newborn, actually really from in the belly, all the way through delivery, through any sort of young age, all the way up until later, up into the hundreds, really any age. All different kind of complaints. We have some people with chest pain, some people with belly pain, some people who can't breathe, different acuities, meaning some people that have more minor complaints, the I stub my toe complaint, other people that have been shot in the chest and they need to be seen a little more sooner. And then they all have different evaluations. Some people just need a prescription refilled. That takes me 5 minutes versus, the person with the gunshot wound is going to take a little bit longer. I make a lot of phone calls. I call a lot of consultants, a lot of other specialists, a lot of primary care doctors, and then a lot of people in the hospital when I'm admitting people that need to stay in the hospital and need more care. I do a lot of advocacy. I think a lot of doctors do, and I especially feel that in the ER, because no one likes when I call, because usually I'm giving them more work. I'm saying, hey, I have a patient here who really needs da 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 da. He needs your services, or they need this procedure done, or they need this medication. I'm asking you to help them. And I do a lot of that to try to help my patients get the things that they need. A lot of charting, of course, everybody does. And then a lot of dispo, What I mean by dispo is dispo. It's short for disposition. As patients come in, I need to be mindful of moving them through the ER, whether that's that they're going home, whether they need a little bit of treatment and reassessment, or they're getting admitted, because as I'm seeing them, people continue to accumulate in the waiting room. When my shift is done, I sign out and I peace out and I go home. This is a little flavor of the different kind of things that we see in the emergency department. So we see any life or limb threatening emergency and everything else, because people come to the emergency department when they're worried that something's happening. And it's our job to figure out whether it's something serious that needs attention right now, or if it can wait and be evaluated further in the outpatient setting. So it's not on patients to know that. So they don't know anything that worries them. They come in, we look it up and try to evaluate them and get them on their way. So we see, I mean, we're specialists in essentially everything. That's why they call us the jack of all trades, because we see a lot of different things. And this is a short list of the things that we see. This is an idea of my schedule. I think this was about a year ago, New Year's. So this was last year. You can see we work different sorts of shifts, and it really depends on the group that you're working with. But I work about 120 hours a month, and that's me working at least 108 hours a month in my group to be able to keep my benefits. And each month I work about 2 to 4 nights. My shifts range 8 to 10 hours each, and I work about 12 to 15 shifts every month. Because it is shift work, I don't really consider having call, because we don't have call in the sense that people are calling us to ask us to be doctors on the phone. If I'm getting a call, that's because it's so busy, they need me to come into work. And there's usually a designated time, like 1 24-hour period a month, that I could potentially get called into work. But I don't see it the same as call, because no one's calling me in the middle of the night or when I'm away at work to do work on the phone. This is an idea of the different fellowships and practice settings. So the great thing about emergency medicine is there's so many different things that you can do. After you do your residency, this list with starting with addiction medicine down to wilderness medicine is just once again a flavor of some of the different things you can do. You can learn about hyperbarics, you can learn about toxicology, and be working at like the Poison Control Center, neurocritical care, aerospace. We have emergency physicians that are in NASA and that go out to space and practice there. That's really cool if that's something that you're interested in. And then depending on where you're practicing, an academic hospital with lots of different specialists there versus a community hospital with fewer resources, that changes your practice. Whether you work in an ER that's part of a hospital, which is what most people consider to be a traditional ER, but there's also freestanding ERs. So anybody that needs a hospital needs to get shipped from the ER to a hospital, or versus an urgent care. They all see different sorts of things. Whether you're at a trauma center or a center that doesn't see trauma patients, whether you're in a place that sees pediatrics only or adults only or both, or you work at a place that has that sees everybody and an emergency physician that's seeing pediatrics only. And then the support specialties that you have in your hospital. So where I work, I have OBGYN, which was really important to me because it's not my favorite thing to deliver babies. I've done it, and if it needs to be done, I'll get it done, but it's not my favorite. So I really like to have OBGYN in my hospital 24/7 there to support me. Whether you're working urban or rural, your resources are different. You could be working for RVU, which means that you're getting paid like fee for service versus just a flat salary, regardless of the amount of work you do while you're at work. Whether you have other doctors or other advanced practice providers, that's like MAs, not MAs, nurse practitioners and PAs that work alongside with you. Locum tenens, that means you're like a traveling physician. Airplanes, you're basically a doctor anywhere. So you can be useful a lot of very different places. So the average salary, we fall about in the middle. The average is about $357 annually, and there is a lot of regional variability. So where I am on the East Coast, we're on the lower end of this spectrum versus some places in the South or closer to the West Coast have slightly higher salaries. Things that I considered pros about emergency medicine is I really like the flexibility. I like the flexibility in schedule. I like that I have a lot of time to do lots of other things in my free time. Like my whole life is not work. Being a doctor is one part of my life. And I love that. I have a family, I had kids during training, and I had a lot of flexibility there to manage all of that. Was it easy? No. Was it crazy? Yes. But it was absolutely all worth it. And now I'm learning to get a much nicer balance, especially as an attending. We get to do a lot of aggressive interventions and see immediate results versus managing things in the outpatient setting that you kind of tweak medicines over weeks to months to kind of, you know, for example, bring a blood pressure down. If you come in and your heart rate is 300, which it absolutely should not be, I can push a medicine in about 60 seconds, it'll be normal. You can't breathe, we can put on a duonub, and within a couple minutes, you see immediate results. And that's pretty cool. That's really satisfying to be able to make that kind of a difference in a patient's life. We see a wide range of pathology. That list that I showed you, there's nothing that doesn't come in through the ER. So at some level, we interact with all different sorts of things. We don't take call. I really like that. And pro or con, for me, patient relationships was not something that was particularly super important to me. I know that kind of sounds callous. I don't know how to phrase it any other way, but if you feel that way, that could be a pro for you. If not, it could be a con. So consider in the ER, many times we see patients and we send them on their way. Either they get admitted to get a procedure done, or they go home to take a course of antibiotics. You never really hear what happens after that because you never really, follow up with them. That's what they do with their primary care doctor. So, that's a pro or con. Other cons are, it is quite unpredictable. It is always chaotic. It's pretty crazy. We have a lot of sleep disruption. That's something that we kind of get educated on, how to manage our sleep and have good sleep hygiene because we're bouncing around different shifts. We work nights, weekends, holidays versus some people, other specialties may have a call system so you can have certain holidays off. And we do get to prioritize holidays. And I've been pretty happy with the holidays I've gotten off because I work in a really awesome democratic group that's run by ER physicians. So we manage ourselves very nicely. Burnout is always a concern just because of the stressful environment we work on. Imagine COVID and what you've heard about ER physicians in the last year. Burnout is a very real thing for us. So emergency medicine might be right for people who want to know a little bit of about a lot of different things versus knowing a lot of things about one organ system. For instance, ophthalmology, ophthalmologists are awesome. They are super experts in one organ system and they know everything about it. This is the opposite in the sense that we know a little bit about everything because we see everything. Multitasking, if you can have your hands in a couple different things, or you have what we call like an ADHD type personality, and multitasking is something that's that's something we do a lot of in emergency medicine, and you need to be able to do. You need to be able to remain calm under pressure and chaos and literally make life and death situations. If you're not, you don't have to be that way already to go into it. You get a lot of training to be able to manage these different situations, and you'll have a lot of support in that. Just know that that's kind of part of our experience. We also have a lot of intense experience, and I want to mention there's a lot of really intensely good and powerfully emotional experiences that we have that also contrast a lot of the more severe or bad experiences that we have. You want to get down and dirty? Yes, we do it. Any sort of bodily fluid you could possibly imagine, it's been on me, I've been soaked in it. We get down and dirty. We want to do, you want to do what you have to do to get the job done for your patient and what they need. And if you have an interest in procedures, so when I was choosing my specialty, I was between OBGYN, surgery, and emergency medicine. I really like the procedure aspect of the other two specialties. but I wanted to have a different balance with some of the more clinical things that I did. So in emergency medicine, I don't operate in an OR by any means, but I do procedures such as intubation, cricothyrotomies, chest tubes, thoracotomies. We do defibrillation, central lines, and ultrasound guided lines. So I do like that. And if you want this flexibility that I'm kind of describing that we get in our schedule, and also where you can go with this specialty, this is something you should consider. So I'm going to go into a couple cases, but maybe this is a good time to just pause and see if anybody has any questions. Let me see if I can figure out how to see the chat button. Anybody have any questions? Anybody thinking about emergency medicine? Drop it in the chat. Okay, I think we are good. So here is, the hardest case that I've had so far. You know, this, like, I'm so sorry. This is like one of the least favorite questions I have, because I feel like it always comes loaded with like people looking for some sort of like entertainment value. And I'd say the hardest cases I've had were not the happiest cases, and they bring me to a real dark place. So I think cases with children that don't do well are probably the hardest to deal with. High school, that's awesome. That's good to know. I wanted to see where everybody's from or where you are in your educational journey. So you're in high school, same, lots of high school, cool. Yay. College sophomore, pre-PA, that's awesome. Pre-PA, this, you know what, I work with a lot of PAs, and you know, there's like a quite developing, you know, home for you guys in emergency medicine, and there's definitely a place. So this is one of the fellowships that you guys actually have as an option. I don't think it's required, but in my residency program, I went to Einstein Medical Center in North Philadelphia. We had PAs in my residency, so. Is there something I did in high school related to medicine? Yes, I did a lot of shadowing wherever I could, whether it was in the hospital, whether it was in the clinics. I just even asked my own doctors, like, hey, how can we set up a little bit of shadowing? Because that's how you see a window into the day-to-day. You know, when you're considering medicine, you need to know what's involved in the training, what the steps are to get to medical school, but you also want to know what the day-to-day is like, because it's a very long journey. And if you don't feel like the day-to-day is worth it, or you find it enjoyable, it's going to be really hard to deal with when you get to the end of the journey, and if you don't enjoy that. And there's a lot of different things you can do in medicine. So I'm going to walk you guys through a couple cases so you can kind of see like what it's like, my patient interaction. So the first one, this is a 70-year-old male who comes in with a sharp intermittent, that means coming and going, right flank pain. He's never had anything like this before. Nothing seems to make it better or worse for him, and he hasn't taken any medicines for this. Those of you pre-med school or around to med school, if you started doing like case-based learning, this is kind of what it's like, how you learn in medical school. So there's a lot of acronyms and things, and I'll read them out for you. So review of systems, he doesn't have any chest pain, no shortness of breath, no nausea, vomiting, no urinary symptoms, no fevers or chills. Past medical history, he has hypertension, hyperlipidemia, coronary artery disease, and diabetes mellitus. Past surgical history, he has none. His social history, he smokes tobacco, denies alcohol or illicit drugs. He's married, and he is a retired teacher. Meds he's on, he takes aspirin, lisinopril, metformin, and he has no known drug allergies. So this is how we think about a differential diagnosis in the ER. This is what I learned in my training. you know, you can make a list if you have time to sit down of a million different things that this could be. But in the ER, I want to think of 3 things that can kill you right now that I can intervene on immediately to stop, and then 3 other things that are maybe more common and less lethal to you. So for this guy, I would think a STEMI, that's an ST elevation myocardial infarction, that's a massive heart attack. I would think about an abdominal aortic aneurysm, or a AAA. That's a large blood vessel that runs through your belly. You can develop a balloon in it called an aneurysm. And when it ruptures, you can lose a lot of blood there and you can die very quickly. And I think about mesenteric ischemia. That means not getting enough blood flow to the blood vessels in your gut. And that can cause a lot of pain. And that can make you very sick very quickly as well. 3 more common things, but less likely to hurt you immediately, would be cholethiasis, which is gallstones, or cholecystitis, which is an infected gallbladder. Pyelonephritis is an infected kidney, and appendicitis, many of you guys are probably more familiar with, is an infection within one of the small pieces of intestine in your belly. So I will walk you guys through this. This is what an exam looks like. So at the top, you see vital signs. So vital signs are vital for a reason. These are the things that are taken in triage, and they give us a lot of information on how sick a patient is and how we can, you know, who to see first. So the temperature, temperature is 97.6 Fahrenheit. That's normal. The heart rate is 101 beats per minute. That's what we call tachycardic. That's a little bit high. Blood pressure, 78/44 millimeters of mercury. That is low. Respiratory rate is 24 rates per minute. That is high. And then the saturation, oxygen saturation, is 98% on room air. So that's pretty good. So on an exam, generally, he looks uncomfortable, he's pale, he's diaphoretic and sweaty. Cardiac exam, regular tachycardia, meaning it sounds like the beats are going pretty regularly, but they're fast, versus something like atrial fibrillation or another dysrhythmia. He has no murmurs, gallops, or rubs. Those are all abnormal lung sounds. All abnormal heart sounds or heartbeats. His capillary refill is less than 2 seconds in all 4 of his extremities. That's pretty good. And he has 2+ radial pulses and 1+ femoral pulses and dorsalis pedals. So the radials are in your wrist, femorals are in your groin, the DPs are on the top of your foot. So respiratory, his lungs are clear to auscultation bilaterally. He has no wheezes, rhonchi, or rales. His GI exam, so his belly, it's obese, it's not distended, and it is diffusely tender to palpation, means like you're touching on it and it hurts. And he has rebound, okay? So that's really concerning. That means when you push down and you let go, it hurts worse. That means there's some sort of peritonitis and inflammation within the abdominal lining, and usually we get worried about a surgical problem there, and no guarding. His genitourinary exam, always really important to do in anybody that has abdominal pain, because there's things that can be going on below the navel that actually cause pain that are higher up in the belly. So you don't want to be misled. He has normal external genitalia, no rashes, no tenderness, and his neurologic exam, he's awake, alert, oriented ×3, no focal deficits. So for this guy, the things I'm going to do, because I'm pretty worried about him, I'm going to, get an IV on him, get oxygen if his oxygen levels go down, and get him hooked up to a cardiac telemetry monitor, get an EKG going to evaluate the heart, just because in case this is like a red herring for a heart attack, get some labs. So these are the labs I would get. If you don't know what they stand for, do not worry. It's just a whole host of labs specific to what I'm worried about on this guy. I would get some fluids going for his low blood pressure and blood products as needed. And then imaging. Now, I'm worried that this guy has a AAA, a ruptured abdominal aortic aneurysm. So I could get a CAT scan, or I could get a point of care ultrasound. And we'll talk a little bit about that. And then his code status. This is where I have to take a minute to say, sir, I'm very concerned this thing is happening with you. It is essentially lethal if we do not act, and it could be lethal very quickly in minutes. And I want to know what your wishes are should your heart stop. So I'm going to opt for the ultrasound, and I'm going to show you guys that's right here.
This video clip is another short axis orientation of a very large AAA in a patient who presented to the ED with abdominal pain. We mark the spine as our landmark, and on anterior to the spine, we see a very large AAA. Notice the true lumen and the accumulation of thrombus that's seen substantially anterior to the true lumen. Next, we'll measure this AAA, and here we've placed our calipers from outer wall to outer wall in a short axis configuration, and we come up with an aneurysm of 6.3 by 5.8 centimeters, again, making the criteria of a
I'm
very
sorry. We
centimeters.
can't see the video actually playing for some reason.
Oh, I am so sorry. Okay, no problem. We'll just skip it. I'm so sorry about that, you guys. That's such a bummer. So basically, it's an ultrasound. We do a lot of ultrasound. That's what I wanted to bring up. I get trained in ultrasound, so I do it, you know, on many of my patients actually. So I do it when they have abdominal pain because I look at gallbladders. I can look at a abdominal aortic aneurysm. I do it of the heart to look at the heart function and look for fluid around the heart. I do it of the lungs to look for fluid in the lungs. I do it for pregnancies. I do it for pelvic complaints. We do a lot of ultrasound. So that's why I just wanted to share this image with you. This patient, I'm worried about having a,
This video clip is
can you
another
see it
short
here?
axis orientation of a very
Yes,
large
now we can see it.
presented to the ED with
Okay,
abdominal
great. This
pain.
is working.
We mark the spine as our landmark, and on anterior to the spine, we see a very large AAA. Notice the true lumen and the accumulation of thrombus that's seen substantially anterior to the true lumen. Next, we'll measure this AAA, and here we've placed our calipers from outer wall to outer wall in a short axis configuration, and we come up with an aneurysm of 6.3 by 5.8 centimeters, again, making the criteria of a very large AAA greater than 3 centimeters.
So that is, okay, I'm glad you guys were able to see it. It usually never works in there, but the one time it worked, I mean, that's awesome. So this guy has a abdominal aortic aneurysm. That means that transverse diameter is greater than 3 centimeters. And if you go down to where the aorta splits into the internal iliacs, if that is greater than 1.5 centimeters, so just half of the 3, that counts as an aneurysm as well. In men, so surgery in men, you get if it's greater than 5.5, and for females, if it's greater than 5. This is pretty rare. It's 4.5 per every 1,000 people, and 85% of them are infrarenal, meaning they are inferior or towards your feet compared to where your kidneys are. Risk factors, so atherosclerosis and high cholesterol, smoking, hypertension, hyperlipidemia, being a man, being older, having some syndromes like Marfan syndrome or Ehlers-Danlos, these put you at high risk for having this condition. And men actually get screened for this in the United States. So it's a recommendation that any man between the age of 65 and 75 who've smoked ever in their life should have an ultrasound just to take a look, to screen them for this condition. In the emergency department, you know, the classic, what we call textbook, what we, you know, put down for our board exams, it's going to be a patient that has back pain, has hypotension, and an abdominal mass that looks like it's kind of pulsing. So in real life, only half the patients might come in with these symptoms. And this is so difficult to diagnose sometimes, that a third are actually misdiagnosed the first time, and they have to go home, you know, and come back because something else happened. This can also present with syncope, which is passing out, or chest pain. So the gold standard to diagnosis is a CT angiography of the abdomen pelvis, but that's in a stable patient, okay? So we have a mantra in emergency medicine. Nobody unstable goes to the tunnel of death, okay? That's what we call the CAT scan. And I don't say that to be brash, but like, you know, you cannot send anybody who has unstable vital signs to the CAT scan. Like, you have to be with them at all times because it's just not appropriate. So an ultrasound is what I would do for this patient who is really sick. He's got low blood pressure. He looks like crap. It's a good thing we have ultrasound because we can do that instead, and we can still take action. This can be diagnosed on an ultrasound. So if somebody is symptomatic, means that they feel some symptoms from this aneurysm and unstable, so just like our patient, I would do an ultrasound and I will call vascular surgery right away. He needs to go to the operating room if we want this man to have a chance to live. In the meantime, while they're getting the OR ready and we're making these phone calls, we're going to get 2 large bore IVs in, we're going to give him some oxygen, get him on continuous cardiac monitor. We're going to support his hemodynamics with fluids, with some blood. We're going to control his pain, and expectant management means if we did nothing, he would pass. If he was having symptoms like, okay, you know, I'm having this back pain, I'm having this belly pain, and we found this and he's stable, meaning he has good vital signs, his hemoglobin's okay, blood pressure is okay, I will call vascular surgery, and they may say, hey, we'll admit him and we'll repair it in the morning, or okay, he can go home and we're going to repair it early next week. It's not the same as, you know, somebody that's unstable that needs attention immediately. And then lastly, if I was looking at his gallbladder because his gallbladder is infected and it needs to come out, and I just happened to see his aorta is a little bit big, that means it was incidental. I found it when I wasn't looking for it. And as long as he doesn't have symptoms or problems related to the aneurysm, he can see vascular surgery in a less urgent manner. You know, in the next 3 months, he can follow up and, you know, have that taken care of. So these are just some clinical pearls. I think I skipped some of my other ones, but for anybody taking boards and steps and things like that, anybody who's having rectal bleeding and they've had their AAA repaired before, that's an aortoduodenal fistula. That's when your aorta, after it's been repaired, it starts to form a connection into the duodenum that's part of your intestine. So now you have blood that's going into your intestine, and that's why it's coming out of your bottom. Well, not yours, your patient's. So the second case, just to shake it up a little bit, and then I will be all done actually. So I see everybody. I see kids all the way up to, like I said, I mean, what we call it, womb to tomb. So I see kids, and here we have a 3-year-old. He's brought in by EMS, by his mom, because he has some shortness of breath for the last 3 days. Progressively worsening and associated with some rhinorrhea, which is some runny nose, some sneezing, throat pain, non-productive cough, no fevers or chills, no sick contacts, meaning nobody around him is sick like mom. He has asthma, and his mom, they ran out of the meds in his inhaler last month, and they can't get in with their pediatrician just for whatever reason. So as we want to know in any kids, what's their vaccine status? They've had vaccine, he's had his vaccines, including influenza. Okay, that's fine. I care less which way it is, because I'm not here to lecture parents. I really want to know, just because it's going to change some of the interventions I might have to do going forward, or some different diagnoses I have to think about. And as we want to know in asthmatics, he's never been intubated. Last exacerbation was 1 month ago. Past medical, as we know, he has asthma, he also has eczema, and he's allergic to peanuts. Past surgical, none. Social history, he's in preschool, he lives with his mom who smokes cigarettes. So, okay, that might be an environmental inciting factor to his asthma exacerbation. He lives with his dad and an older brother. His meds are pretty typical for some patients with asthma and eczema, and he has no known drug allergies. So things that I'm worried about now, 3 things that can, you know, be real harmful, and then I need to intervene on not now, versus 3 things that, you know, less harmful. Asthma exacerbation, obviously. This guy has asthma and he's got symptoms of asthma. That can, you know, go 0 to 100, and people can die of asthma exacerbations. That's not a joke. Anaphylaxis, he's having a severe allergic reaction in a foreign body. He's 3 years old, you know. Generally 3-year-olds are pretty good, but you never know if he just, like, you know, found something on the ground, a bead, a magnet, you know, whatever, and tried to swallow it, and now he's it's in his airway. Other things that are less lethal, typically an upper respiratory infection, that's a common cold, a pneumonia, depending on how sick they are, and always on our differential with kids in any situation, child abuse or neglect. These are things we always have our eyes open for, that we are trained for seeing, because you never ever want to miss that. So his vital signs are the exact same as the other man's, the first patient's. However, for a 3-year-old, these are normal. So I always carry my pediatric card because kids are so dynamic as they go through, like, birth to their first year. Every few months, there's different markers that you're looking for. Their vital signs also change as they age. So I always carry my card because I can't remember. It's really hard to memorize all of this. So on his exam, generally he's in no acute distress. His HEENT exam, so head, eyes, ear, neck, and throat. His pupils are equally round and pupils are equally round to light and accommodation. He's got a little bit of clear rhinorrhea, his moist mucous membranes, mild pharyngeal erythema, meaning a little redness in the back of the throat, no exudates, so none of the pussy white stuff on there. His uvula is midline, his neck is non-tender, it's full range of motion, and he's got a little bit of cervical lymphadenopathy, some lymph nodes. So as you can notice, this exam is much different than the exam I did for the other patient. We cannot afford to do a full head to toe, which your primary care doctor may be doing, because we're here for a very focused problem. So we want to do the best exam of where we think things are going. We do a general head to toe, but it's not going to be the same way I was doing for this last patient. I didn't really do a head and neck exam this way. The cardiac exam, I'm going to tell you, is normal. The respiratory exam, symmetric expansion, a little bit of expiratory wheezing bilaterally. Okay, that's consistent with asthma. The belly exam, soft, non-distended, non-tender, no rebound or guarding, that's good. Neuro exam, his exam's also different because a 3-year-old's neurologic function is much different than a 75-year-old's. So he is awake, alert, playful, he can follow my directions, and he doesn't look like he's having any focal deficits, like his leg's not moving, like one leg's not moving or something. And on skin, he's got no rashes. So for this kid, I'm most concerned he is not as sick. He's more stable, and that he's having an asthma exacerbation because he ran out of his medications and he may have an irritant at home. So he gets some duonebs, that's an albuterol and ipratropium. So you have your beta agonist, and then you have an anticholinergic, and then some oral steroids. I'm going to give him some time, circle back in about 30 minutes, and I'm anticipating he'll be able to go home. But I'm going to do a couple of things for him to go home to make sure he's wrapped up the best that I'm able to. I'm going to give him the prescription for his steroid burst and make sure I refill his albuterol inhaler and make sure he has his EpiPen. This is part of trying to be complete. He's having difficulty getting into his pediatrician, and I'd like to help him out in the meantime and try to keep him as healthy as we can. Anticipatory guidance, that means talking to mom and dad about what to expect when he goes home. So he's having an asthma exacerbation. If he goes home and he starts to wheeze in 20 minutes, does he need to come back to the ER? Here's how you can decide. And these are 3 or 4 reasons that you should absolutely bring him back, and look out for these. Otherwise, these are your next steps. Help them out. We need to give clear instructions so they know what to expect. And then make sure they are able to get in with their pediatrician. So this is a pediatrician I may call personally to say, hey, we need to make sure that, this patient can get an appointment. And then I might tie in social work just to help mom as she goes home, mom and dad or whoever in the family, after she leaves our care. Pearl, so in kids, when to get x-rays. So we call these the 4 Fs. So if you're worried about a foreign body, if they have a fever and you're thinking about some sort of infection like pneumonia, if they fail to improve with treatment, so you've given them the duonebs and they usually get their duonebs and they get fine, and this person's not getting better, okay, we need to think about that something else might be going on, and we might want an x-ray to take a look. And then fracture or like trauma or abuse, like we said, child abuse is always on our differential. So great job, doctor. We have a code rolling in about 4 minutes. Cards is on the phone to talk to you about someone they're sending in, and 22 patients in the waiting room. So a little bit of advice for those of you considering medicine or going into medicine. So learn a proper exam. You undress your patients until you've seen all of their skin. You cannot say that you've done a complete exam. We cannot rely 100% on all our CAT scans and things like that. People can come in with chest pain and we get so worried that they're having a heart attack that we haven't even properly looked at their chest to realize it's a shingles rash. That's much different and that's much less severe generally. So find and stick with good study habits. They were not kidding about lifelong learning. When they say doctors are always learning, that is true. I will never feel like I know everything that there is about emergency medicine because I never will. I am always studying because people's lives depend on it. Be honest with yourself about what you do and do not like. And that's even about pursuing medicine. And when you're in medicine, picking a specialty at all stages of your life, I would say, you know, glamour and money do not always equal happiness. Yes, money is helpful. You know, the financial situations of physicians, I think, is misleading a lot of times. People can see that, okay, we make maybe $357,000. I'll tell you, I don't. But I also have $350,000 worth of student loans from all of my training. So, you know, that's part of that as well. Fit your medicine life into your real life. So this will be a big part of your life. It was most of my 20s, but I did not let this be my whole life. It is going to be a big part of it, but you are still a person. You still have passions, you still have interests, you still have families, you still have a whole world outside of medicine that you should not forget to attend to and to make time and space for. The white coat investor I recommend to anybody regarding the finances of going into medicine and how to manage money and student loans and things like that. I think it's very helpful because a lot of our money management, the most of it is not like any other professionals. We have a very unique situations, mostly because of our student loans and the length of our training. Hold your head up high, but not too high, meaning be humble, be kind, and listen. Nobody likes the jerk that's a know-it-all or, you know, strutting through the halls like they own the hospital. That's not cool. We're all working to constantly be learning to do the best for our patients, and that requires teamwork. And you don't realize we're not only learning from books. There's every person in the hospital you are learning from, not just patients. Some of the best lessons and things I've learned have not come from medical school or from books. They've come from experiences within the hospital. So be open to that. If you are interested in EM or you're in medicine already, the apps are really awesome. PD-Stat, the EMRA Antibiotic Guide. If you're considering emergency medicine, EMRA is the Emergency Medicine Residents Association. You should check out, as well as the American College of Emergency Physicians. And you can contact me with any questions that you have here at my email. You can see my blog. So I didn't really mention entirely, but I graduated in 2019 and I was working through the pandemic, and then I was diagnosed with breast cancer, and then I stopped working through treatment, and that's kind of where the blog and everything came from. So that has been a big part of my life as well. That was not exactly the focus of this talk. And then you can always connect with me on Instagram. I would love to hear your questions, your thoughts, and continue the conversation. Go ahead. Thank you guys so much for coming. Drop any questions into the chat, or honestly, just unmute yourself. I think that would be fine too. Let me get onto my screen. You're welcome. Thank you guys so much. Thank you, Haley. Thank you, Jordan. Thank you, Angelica, Sophia, Ashley, Chelsea. Thank you guys so much for coming. I hope this was helpful, give you kind of a peek into my world.
So I had a quick question. You mentioned how medicine is lifelong learning, and especially in medical school, I bet you learned a lot. So I was wondering, what are some of the most effective study methods that you've used in the past?
Yeah, absolutely. So I will, once again, I think it's not a one fits all by any means. And I think that's why I struggled a lot in the beginning trying to do what worked for everybody else. What worked for me is studying by myself, not in the group studying or the accountability groups. I learned best by myself, by reviewing my slides and reviewing my notes. And I hand wrote a lot of things. Just handwriting somehow like cemented things into my mind. And I'm a very visual type learner. So I think there was something about I would just have journals where I was just copying and copying the same things. And it just really put it into my head. And I felt when I got to test, I was able to kind of pull it up. I also, if I didn't do so well, I actively sought feedback. I would go to my professors, review my exams, that stuff's never fun, but if you don't know your weak spots or how to get better, how can you get better? I see a question from Faiza. What college did I go to? I went to University of Michigan. So I was born and raised in the suburbs of Michigan. I probably should have started with this, but I'll do it now. I was born and raised in the suburbs of Michigan. I went to University of Michigan. I had a bachelor's of science in psychology. I did my pre-med classes. I took my MCAT twice. We did kind of talk about that. And then I moved to Philadelphia. I did a post-bac at the University of Pennsylvania for 2 years. And I also worked in their School of Social Policy and Practice doing emergency medicine research. I did not know that I wanted to go into emergency medicine. That just, maybe it did influence me and I didn't realize it, but I didn't see it connected at the time. I went to medical school at Jefferson Medical College, which is now Sidney Kimmel Medical College. For me, it's Jefferson Medical College. And then I did my emergency medicine residency at Einstein Medical Center in North Philadelphia. 2019, then I moved to Washington, D.C., where I am now, and I work in the community in Maryland. Part of a Democratic ER group. I think that's everything. Was there a specific moment that affected your decision to choose EM as your specialty? I'm a big pro-con list person. I'm just a list person. I told you I write all these things down. No, I really just made a list between surgery, OBGYN, and emergency medicine, similar to the list that I showed you guys. And EM did specifically allow me the flexibility of having 2 kids in residency. So I'm sure they exist, but not a single other person that I know has done that. There may be, I don't know, 5, 10, certainly not a lot of people that have been able to do that. And I was able to do that. I had awesome support during my program to do that. And I was very upfront. I mean, because I wasn't asking, I was telling. How did you make sure that you would be good under pressure? That's a really good question. Is there a way to prepare for this and test it out? That's a great question. And I'll be honest, I don't know that you can prepare or test it out other than how do you perform now, like how do you perform in certain stressful or friction type situations? I have found it helpful for myself. Some of the more common things, like if I'm going into that kind of thing to keep my stress down, I can afford 3 seconds. No matter what the situation, I can afford 3 seconds, usually because there's way many more hands in there by the time I'm showing up and people are just looking to me for direction. So I have a second to get my thoughts together. I take a deep breath and I tell myself, I just whisper, you got it. And that snaps me into my go mode. That didn't happen overnight. That's where I've gotten after 12 years of kind of trying to work on this. And I think that's a journey for everybody. That's why it's not a one size fits all, but know that it is possible. That's not something that should scare you away if you're at least open to trying that. What do you do if you do not know something or how to treat a patient? That's a great question, Michelle. I ask questions. I've never been ashamed to ask questions. If you think it's stupid, it's, you're asking it. There's at least somebody else in that room that has the same question that's not asking it. And
this happens a lot in emergency medicine because I often don't know the patients. These are all random patients to me, people that I don't have records for, people who often don't come in carrying their medical records either because they're in an extreme or dire situation, or they may not be what we call a great historian. Not everybody knows how to talk medicine. And a lot of times I don't have access to records. So I do the best with the information that I have available to try to make the safest and the best decisions. And I will have those frank conversations with patients, or, if I'm calling a consultant, like X, Y, and Z, I don't know at the time, but these are the things that I do know. Do I struggle with being desensitized to emergency or serious events in my personal life? That's a great question, Christian. I will tell you, because when I was diagnosed with breast cancer, my life was flipped upside down, and I'm in this very weird balance of desensitized and sensitized, having now been in the patient's seat and going through surgery, multiple surgeries, going through chemotherapy, and, all of that kind of thing. How did I combat this? Prior to having breast cancer, I did not combat it because it's what allowed me to cope with the work that I did. The ways that I did cope also were to discuss with colleagues. So, we have HIPAA and patient privacy. So I can be in a very emotionally awful situation and then have to turn and go into the next room, and the patient's pissed off at me because I've been missing for 20 minutes and not be able to, you're like, if you only knew what I was doing, I think you would just be a little bit nicer to me, and I'm trying to help you out. So to be able to take a moment, like I said, take a minute to myself where I'm going to just breathe and reset my mind, or to debrief with the colleagues that I can talk about, the ones that were there side by side and know what that experience was, I think that's very helpful in having that support. But being desensitized is part of how I cope. That's a really good question. Not to get all philosophical. When you were a resident, were you scared or nervous going into your first? Yes, I'm still scared. Sometimes, I'm going to be honest with you. I can't pretend I walk into everything, 100%, like, no, I still get scared. But I think that's being human. And I think it actually helps me to think through my decisions in a way that is better for my patient versus just making assumptions based off confidence, So I like that part of my decision making right now. Do you ever have patients come in who are looking for a diagnosis after they have exhausted all other specialists? Yes. And I tell them, unfortunately, I am so flattered that you have come here, but the emergency department is not where I'm going to discover a deep hidden diagnosis. And that's a misconception I think patients have. The function of the emergency department is to identify any life or limb threatening condition, any emergency, and stop it and treat it. Stroke, heart attack, surgical emergency. So that's what we're looking for. So when people come to me for that, I try to at least set realistic expectations too, because I don't want them, to start ordering all these tests and get this $1 million workup for them, knowing that I'm not going to find the answer. And I like to be upfront about that. Would I do anything differently? I am at a place, so I am in remission from breast cancer right now. I know that question's not about breast cancer, but I'm at a place in my life where I feel good emotionally, physically, professionally, personally, and I would not have gotten to this place if I didn't go through the experiences exactly the way I did. And I don't like to, think about regrets. So no, I can't say I'd do anything differently. These are some real good questions. When I look at a patient's past medical, is there anything that stands out to you more than others and worries you whenever? how do I answer this? Yeah, I think there are. I don't know that I'm gonna pick through and identify all of them, but as you practice, I think you will notice trends or certain things that you'll see in patients' charts that, you know, you're like, okay, there's definitely not patient types, but you're gonna know like, okay, this, you know, this patient sees a lot of specialists, or this patient comes to the emergency department a lot. And a lot of times it doesn't end up being something. All that being said, it's a very dangerous way of thinking. So yes, but I'm not going to be any more specific than that. Yeah, but you know, I see the police coming in. So we have a lot of violence in the emergency department, and that it is a federal crime to take those actions or to try to harm a physician. And I try to be very up clear with that and be up clear with my patients, you know, depending on what the situation is that they're so aggressive about or coming in with police escort. All that being said, as long as I can have a reasonable conversation with my patient, it's not for me to be judging the situation that has brought them there. Those things hinder my ability to connect with them, and connecting them, with my patient the best that I can gives them the best care from me. So it's hard not to be clouded by like police and, you know, different circumstances, but if they can be calm and, you know, we can have a real conversation, we can usually work through things. I don't know what it is. You know what? You just never know. Sometimes it's just some random night. Maybe it is a full moon. It's like a full moon, it's a half moon, it's a half crescent. All of those times, it's a great time to be crazy in the ER. These are some great questions. Thank you guys so much for joining. Thank you guys so much for having me. Please do reach out, social media or through email. Continue the conversation and ask me any other questions.
Thank you so much for coming. Your talk was amazing. I loved everything. And I just loved having you here, and thank you so much for coming.
Absolutely. All right, take care, guys.
Thank you.
Bye.